All right, all right. Well, I just introduced Doug, so I'm sorry I didn't get you on the link here.
Oh, no worries.
We will see. We'll share our screen. Let me switch our screen real quick.
Oh, you just introduced Dr. White.
I don't have a laser.
Try and stay behind the podium so the people watching on Zoom can hear and participate. So this is Wisconsin. I took this picture last week. What it really, no, okay. But believe it or not, you guys have way more snow than Minneapolis does at the moment. So most of the storms so far for us this year have been passing to the south. We'll see what it looks like tomorrow when I try to go back. Tomorrow, I'm going to spend more time talking about this project that is pretty old and relates to the microbiome and what we refer to as the virome and the effect of the passengers, the microbiologic passengers that we carry around on our health and on our immune system. Today, I'm going to pass over that. We can go back and talk about it and answer questions about it if you're interested, but in the interests of trying to save time, I was going to jump ahead and talk a little bit more about ACR stuff for this audience, since I think many of the people in the audience tonight will have the opportunity to go to Grand Rounds if they want to tomorrow. So thank you very much for the invitation to be here. And when I first talked to Marcus about coming to Omaha, he says there was an interest in Medicare Advantage plans. And it fits in pretty well with a lot of the advocacy efforts at the ACR, which I think you're pretty familiar with. But I still find that there's a lot of confusion, especially around the vocabulary and the terminology and some of the specifics related to Medicare coverage and what we're actually advocating for, and the problems that we have when we're trying to obtain access, especially to medications for our patients who have these various levels of coverage. So in hopes that this is what this group was looking for, I hope it was, I hope this is a discussion, and you'll let me know if this isn't what you were looking for. In hopes this is what you're looking for, I want to give you just a little bit of a primer about Medicaid and the way, Medicare and Medicaid and the way I think about it. This was heavily influenced by a talk my program director gave to me when I was or gave to our group when I was a first-year fellow in St. Louis. We were all confused, and he tried to explain to us the difference between Medicare and Medicaid, and it's expanded since then. And so I'll try and share a little bit of that with you tonight. So on the left, you simply see a timeline from a really nicely done review in the New England Journal just a couple of years ago about the history of healthcare coverage in the United States and how that contrasts with other places in the world. Mostly for this, I just want to highlight that Medicare is pretty old. It goes all the way back to 1965, but things like Part D are much newer, and Medicare Advantage came along right about the same time as that too, so much newer from a historical standpoint. On the right, you'll see an average across the United States of the payer mix, and about half of the country is has commercial coverage, and about 35% or so are going to have government non-military programs. So in other words, it's a substantial portion of our patients that get these get their health insurance through government programs. And as I think everybody in this audience is well aware, it is absolutely astonishing how small changes in that pie graph on the right affect the bottom line of a large healthcare organization. A small healthcare organization with a 1% shift into or out of commercial will see maybe $500,000 change in their bottom line on an annual basis. A medium-sized organization, about $1 million, and a large organization can easily see $10 million drop down to their bottom line with a 1% shift into or out of commercial payers. So your payer mix makes a big difference in terms of the bottom line of the organization. This is not a pretty slide, bunch of information on it, really to just hopefully facilitate a conversation. I apologize for all the words and trying to cram so much information into just one slide. But I don't think it makes a lot of sense to address these things individually. They're interacting parts with each other. And I think unless you can see them all up on the screen at the same time, it's a lot harder to understand. So let's start at the beginning with Medicare, what we now call original Medicare, which goes back to 1965. And as everybody's aware, this comes in two bits, Part A and Part B. Part A is sometimes referred to as hospital coverage, and Part B is sometimes referred to as medical coverage. That always confused me. I thought hospitals were pretty medical, not to the people who made the government lingo. But the Part A, of course, as you're aware, covers things that we mostly think about as inpatient care. But there's quite a bit of outpatient care associated or covered by Part A these days too, including hospice care and home healthcare services. If you had a full-time job and contributed to Social Security through your job for a long enough period of time, there is no premium when you reach 65 years of age to get Part A. If you didn't work full-time long enough, or you worked only part-time for a few years on and off, then there may be a premium associated with Part A coverage when you become 65 years old. Part B is the outpatient stuff. That's what, this is where your reimbursement when you see Medicare patients comes from. And this also includes things like PT and OT and even some preventive care. Patients do pay a premium for this. But the important part is that Part B really only covers about 80% of the cost of the billable goods and services. So there's a 20% coinsurance. And importantly, it's not capped. There's no maximum out-of-pocket for Part B. And that fact, I think, more than anything else, is what is driving patients into Medicare Advantage plans, which we're going to contrast with Part A and Part B in just a few minutes. But remember the fact that there's no cap. So as healthcare costs go up and you're responsible for 20% of your coinsurance, or you have a 20% coinsurance on your outpatient care, the possibility for absolutely outrageous and really unaffordable outpatient costs in that Part B bucket is what is not only preventing a lot of our patients from gaining access to the drugs that fall under Part B, but is also driving patients into Medicare Advantage plans. The next thing that came along was named Part D. It wasn't named Part D because they were going A, B, C, D. It was named Part D because of drug. And Part C came along later. They just used C to fill in the gap. But prescription drug coverage didn't come about until much later in 2003. And this is provided by private insurance companies contracted through the US government and can and often is a standalone policy. So if you are going to pursue your healthcare coverage through Medicare, through old-fashioned original Medicare, you apply separately to Part A, you apply to Part B, and you apply to Part D. In contrast, some patients will also get Part D coverage through one of these Medicare Advantage plans. Again, we're going to hit that a little bit harder in a minute. And then it's all lumped together. They get A, B, and D all in one application. That's another convenient thing that's very attractive to the patients. They don't have to take care of the administration of 3 separate health insurance plans, Part A, Part B, and Part D. They can just do one. Medicaid, we'll talk about in contrast to Medicare in a minute. We do have a pediatrician in our midst tonight. There he is, knows far more about Medicaid. He's forgotten more about Medicaid than probably most of us have ever known. Another term that I find confuses people is this idea of supplements. So supplements came about and got nicknamed Medigap coverage because of this high out-of-pocket costs. So the whole concept with a Medicare supplement is to just have another piece of insurance that helps pay for your crazy high out-of-pocket costs from your inadequate Part B coverage. That's different from Medicare Advantage. And then Medicare Advantage is officially called Part C, and that was inducted in 2003. Okay, a quick side note. This is Medicare versus Medicaid. Medicare is administered through what are called MACs. These are regional. You probably have 1, 2, maybe how many MACs do you have in Nebraska? I don't know, just one. And it's multiple states. You share it with a couple other states. Some states will have a MAC that divides the state. Other states will be grouped with a couple other states that have a MAC. This is important from an advocacy standpoint because you can be a physician on the MAC that represents and is a voice of the physician community at that contractor. MAC stands for contractor, and influence some of Medicare's coverage decisions through that participation and advocacy route. Medicare, of course, is for people 65 and up. People also, after 2 years after your disability, you're eligible for Medicare, and this is also what takes care of people with end-stage renal disease. There's no drug coverage built into Part A and Part B. That's why Part D came about, and the coverage is assumed. That doesn't do us any good because another way to phrase that coverage is assumed is you don't need prior authorization. It doesn't do you any good because in the office, so many of the patients are going to have a supplement that you still have to get prior authorization. So we're not getting off the hook. And it's not less administrative burden with Medicare than it used to be because of the supplements. Again, covers about 80%, and that drives the need for the supplements. In contrast, Medicaid is pure state to state, and some states do it well, and some states don't, and there's a lot of controversy about that. It's based on your level of income, and there's this thing called a spend down. So you can have a job and you can have income and still be eligible for Medicaid, but you may end up, depending on how much money you make, having a deductible on your Medicaid policy that if you're poor enough, you don't have any deductible. Pre-approval is required, and this includes drug coverage, and it's very separate. Most of us don't deal very much with Medicaid. Pediatricians and academic healthcare centers deal tremendously with Medicaid. It doesn't reimburse very well, and it's one of the reasons that we're having trouble recruiting and building pediatric rheumatology sites around the country is because they're so dependent on Medicaid, which underpays. Okay, another ugly slide, sorry, but hopefully it's organized in a way that can help the conversation and put things into context. So these are Medicare Advantage plans. It's called Part C. And the Medicare and the government consider this a wonderful private-public partnership between the government and private insurance companies. In all honesty, these are run and administered just like private third-payer commercial insurance policies, but the benefits are tied to Part A, Part B, and Part D, right? So what you get is predetermined by A, B, and D, but everything else is going to be very familiar to you like a commercial plan. There are Medicare Advantage plans that just offer A and B, but 90% of them include Part D coverage. Again, this is a big administrative advantage to a lot of our patients because it's one application as opposed to 3 separate applications. They take the form of PPOs, HMOs, and this thing called private fee-for-service. Senior preferred, I assume you guys have lots of senior preferred here. Does that ring a bell with you guys? No? Senior preferred's big in our area. I think it's big in some other parts of the country too. Maybe you haven't heard of that, but it's one of these particular MAs that happens to be an HMO. The benefits, again, are defined under original Medicare Part A and Part B, but the way you get access to the benefits depends on the particular plan, which is determined by the insurance company. So the rules and the costs and the coverage restrictions are all very familiar, and they sound just like private insurance. So because of that, networks apply. So if you have original Medicare and you're a snowbird, you can go to Florida and your Medicare is still going to cover you down in Florida. You just go to another doctor that takes Medicare. But when you have a Medicare Advantage plan under a commercial payer who works out of Nebraska and doesn't cover in Florida, you're uncovered when you're down in Florida in your beach house. Another big difference is in Medicare, there's no official need for a referral to see a specialist, and in the Medicare Advantage plans, everything's run just like a commercial plan where they try to drive everything through the primary care provider. So there's a requirement before you go see a specialist, and so before somebody walks into a rheumatology office, they have to have an official referral. In contrast to old-fashioned Medicare, there, depending on the plan, can be some dental, some vision, and some hearing coverage in Medicare Advantage plans. They're also expanding rather dramatically to try and attract more and more patients. So there's coverage for things like building ramps for wheelchairs in your house, and gyms and acupuncture and a whole range of things that you wouldn't normally think of as being covered. They're not back to hot tubs yet like the good old days, but they're starting to expand into and cover other things outside of the healthcare system, or outside of what you would think of as the healthcare system. A lot of these plans, most of these plans, I couldn't find an exact number, but the patients, in addition to the Medicare Part B monthly premium, will pay an additional premium on top of that. But it's worth it for a lot of patients because of the next one. The co-pays are preset. Therefore, the out-of-pocket costs, especially for somebody with some of our drugs, are much, much lower, even when you take into consideration the extra premium. So they cap their out-of-pocket expenses, and there's no need, but also no eligibility for Medigap or the supplemental coverage. This was an amazing statistic. About half of all Medicare beneficiaries are now in Medicare Advantage plans. But the amazing thing to me was to find out that they're estimated to have 43 different plans available to them when they start to try to navigate this at age 65. So you can imagine what a disaster this is for a rheumatology office, because the number of it's just another whole neighborhood of insurance plans with rules and fine print and administrative burden on top of what you've already been wrestling with. Is this what you were looking for? Does anybody want to tell me about your gripes and complaints and fears and hopes and dreams about Medicare Advantage plans, or things you found wrong or incomplete in this summary?
Very big gripe. I think that there was a question that was raised was by one of our private rheumatologists saying it's been kind of difficult this year specifically. Or back in December, they were having a lot of difficulty with Medicare Advantage plans, and been a big change, a big administrative burden to the practice.
I'm not the slightest bit surprised, and I think it's only going to get worse. I think more and more patients, as the price of healthcare goes up, especially rheumatology patients, and we're trying to get patients into Part B drugs because at least there's some coverage. I think more and more of them are going to find Medicare Advantage plans attractive because of the caps. And it's the wild, wild west when you move over to an MA plan. I mean, imagine how many plans there are nationwide if a given beneficiary just in his or her region has access to 43 separate plans. It's obscene. And there's no standardization, of course. And so it's a nightmare of administrative burden. I think it's going to get worse. Yeah, Amy.
General question. When people hit 65, they're still working. Are they forced into Medicare? So many insurance private programs like force them to take a Medicare and then buy a supplement with them, or does that happen to my mother-in-law? And I thought this is weird. Forced to Medicare and
I wasn't aware of that, but as you were asking the question, I was trying to think to myself, the people I know, the patients I know who are over 65 who have not gone into Medicare are getting coverage on their spouse's policy. So I could see if you had an individual policy or you didn't have a spouse with a policy, how your insurance company could say you're 65, this policy is not available to you anymore, and then dump you.
Yeah, because Medicare is gonna cover a big portion.
Exactly.
Their age, cover a big portion, they're gonna like force you onto that.
Yeah.
and you gotta have stuff.
Yeah, we're going to move you out of our risk pool and you can go over here into the government risk pool. And if you're interested, here's some Medicare Advantage plans that you might want to look at, but they're not going to offer you the same policy that you had before. But I don't think you're legally required to switch. You can continue on after age 65 with no insurance or your spouse's insurance or something else. But your company might not let you continue past age 65.
So is it true? So I was in the military, and we had lots of people that never took Medicaid. And so there was a penalty, I think, probably for Part B. If you did not enroll when you were eligible and waited to enroll. I don't think A probably doesn't matter since you're so treated. Is that still intact? Is that something?
It's a great question. I have no idea. The question is, based on experience in the military and people covered by military policies, they would delay enrollment in Medicare and then pay a penalty for that late enrollment, presumably because they weren't paying Part B monthly premiums since age 65. And so somebody was trying to recoup that income. I don't know the first thing about that. It's a really interesting question. Does anybody know the answer to that?
Have we seen an increase in Medicare Advantage over the past 5 years? Do you know? I don't know. I just noticed that personally, I see more ads with like Dom Selleck and you know, more ads on TV pushing people and you know, putting that carrot in front of patients to join Medicare Advantage.
I couldn't find a graph, but it's clearly picking up, right? The number of people and the number of plans that are available, and somebody's making money off of it because they're advertising.
What do you tell your patients about Medicare versus Medicare Advantage?
This is an interesting question. We tell them watch out for senior preferred. I think the most, well, all right, let me take that step back. The most common stumbling block, I think, for patients of all ages, but especially somebody who has some dementia or doesn't like computers and reading off of websites, the fine print, is just basic education about insurance, right? They have a hard time understanding coinsurance, copay, deductible, premium. These words are just alphabet soup to them. Doesn't make much sense. And so their ability to access it at any levels, very difficult. When you get somebody who does understand those terms, catches on kind of with the parallels with their car insurance, et cetera, and they're understanding it a little bit, our patients frequently get blindsided by not paying attention to drug coverage. So they don't investigate the formulary associated with the plan that they're that they're looking into, that's being advertised to them, and they get told about all these wonderful benefits, and it's going to cover this, and their glasses are going to get paid for, et cetera, et cetera. And they think that's great, and they just assume that their Remicades covered. They just assume that their Actemra is covered, and then boom, they get hit by the train. Or they think they have some great policy, and it's the drug coverage that kills them. It's because of the formulary. And so getting people to pay attention to the formulary is a challenge, especially when they have a known diagnosis. Obviously, if they don't have the diagnosis yet, then what can you do? Because then you don't know what drug you're going to need. So looking at the formulary doesn't help you very much.
Have you heard anything about organizations like Nebraska Medical Association or whatever that are trying to do some sort of formalized education program or put together programs where we can actually work with our patients and steer them one direction versus another? Is that tricky business?
It's a great question. So the question is, am I aware of any state, regional, or national medical societies or medical groups that try to do patient education and steer them, or at least provide them with enough information to make intelligent decisions as they try to navigate this space? I'm not.
So I'm sorry to jump in, Dr. White. In Nebraska, Aging Partners or local area agencies on aging do a great job of teaching people about Medicare when they're getting ready to switch. It's a nonprofit, so they don't have a stake in providing education to to go for Medicare or Medicare Advantage, and then they even help seniors sign up. Did any
Carmen's chiming in and saying that there is a nonprofit in Nebraska, I didn't catch the name, who does a great job of educating people as they're trying to make the transition into Medicare. Carmen, can you tell us the name of the organization again?
Yeah, it's Aging Partners, or your local area agency on aging.
Local Area Agency on Aging, or Aging Partners is the other name. And I'm seeing a lot of nodding heads. People know what Aging Partners is. The thing that I was going to add is I'm sure there are many groups that do this. The one that I'm aware of is AARP, but I don't know any details about the other groups. I would guess, as Carmen is kind of suggesting, that a lot of it's hyper local, right? And based on the plans that are, because it has to be, especially if you go into Medicare Advantage space, because you're tied to the plans that are available in your locale, right? If you choose original old-fashioned Medicare, it's going to be the same for everybody around the country. But if you're interested in comparing and exploring an MA, then you have to know what's available in your town.
It seems like the transportability is a big issue that's not really addressed.
This snowbird question comes up all the time with Medicare Advantage plans.
We don't have that.
Because everybody likes to stay in Nebraska all winter?
It comes.
No, they leave.
No.
You guys don't.
Then they got to deal with that on the other end.
Oh, yeah, so you don't have to deal with it. No, but the patients have to deal with it. Yeah. Yeah. I can't imagine why anybody would leave in Omaha winter. They probably just go Ogallala. It's my favorite town in Nebraska. I just like saying it every chance I get. Any other comments, questions, thoughts about Medicare Advantage plans? How much time we got left? We got to get people out of here on time. They got a snowstorm to beat.
7:30.
7:30. All right. Okay. Let's talk a little bit about advocacy. This is the main thing that I want to convey about advocacy. I got a whole deck of slides talking about the ACR and all the stuff that they're doing. But I'm going to be honest with you. I think it all falls on deaf ears to the vast majority of rheumatologists and citizens in general, because they can't get past the terrible taste in their mouth when they think about lobbying. They hate the concept. They don't want to have anything to do with it. I felt the same. I felt the absolute same until I was dragged in by the ACR and peeked behind the curtain and got a much more nuanced and mature and informed opinion about what lobbying actually is. Does lobbying have an ugly side? You bet it does. Of course it does. Are there downsides to a government system that interacts with its citizens in a lobbying dependent fashion? Of course there are. So the stories you've heard and the downsides and the bad taste, there's a good reason for that. But the vast majority of lobbying, as far as I can tell, especially the lobbying that we do on behalf of our patients and at the ACR on behalf of our members, is of a very different flavor. And I want to talk about that a little bit and try and paint this picture for you so that then when you hear and we talk about lobbying and what, because we don't want to call it lobbying, so we call it advocacy. When we talk about it, it's not so hard to hear about and you're not so put off by it from the beginning. I'm guessing that you're put off by it because so many other audiences are. first thing to think about or understand about lobbying in my mind is it's much more akin to advertising than I think most people realize. If you want to sell a product, you run a business, you have to have an astonishingly well-known product and an astonishingly compelling reason to buy it. And everybody has to agree that it's desirable if you're going to sell it without an advertising campaign. If for no other reason, you just have to simply increase awareness. And lobbying is far more about increasing awareness than it is about convincing people one way or another. So if you want to function in the US system without lobbyists and without lobbying, I challenge you to think about a company that could sell products without advertising. The vast majority of them aren't going to do very well because their products aren't well known enough, aren't compelling enough, and everybody doesn't agree that you should buy it. Number two, lawmakers, members, as we call them when we're on the Hill, are just normal people. And they serve in Congress with very narrow, sometimes minuscule amounts of experience in what we call the real world. Some of them have a background in starting a business. Some of them have a background in this or that. A lot of them have a background in government. There's a few who are actually doctors. So some of them have some relevant experience. Some of them have actually lived what we're lobbying for. Some of them know some things, but the vast majority of them don't know any more about healthcare than you know about plumbing. We can't function in a society where the lawmakers don't understand the system, the healthcare system that we're in and what we need, what our needs are. So there's a lot of education. You have to understand that the people making the laws, writing the laws and making the decisions need the information. There's no other way that we have in our system for them to do it. Number two, they realize this weakness. They're fully aware that they don't know huge aspects of the economy and huge aspects of the things that they're legislating about. So what do? You hire some people who do. Who takes those jobs? 22, maybe. One of the most astonishing things happens to you when you go to the Hill for the first time is how young everybody is. It's flabbergasting, right? These are peach jobs. These are highly sought after jobs. These are highly competitive jobs. And these jobs launch people into wonderful careers. And so the brightest and the best and the smartest and the most driven come from Georgetown, and then it kind of diminishes after that, right? University, and they apply for these jobs and they get these staffer positions. They're smart as whips. They are highly motivated. They're wonderful people. And they don't know the first thing about the real world. They've never done a single thing except go to college. Not one. They maybe worked in an ice cream shop in Decorah. Right? And they're writing laws. It's astonishing. Okay. It's all about relationships. It's all about long-term relationships. For obvious reasons, the lawmakers and the staffers rely on the people, especially the lobbyists, that they have these relationships with for background understanding, and as is notoriously reported in the press on occasion, the actual text for bills, right? So it's not unusual for a lobbying firm to draft a bill and for somebody in the press to get a hand on the draft that came out of the lobbying firm and the final bill that passed Congress and recognize that it's the same. It's the same. Well, there's a reason for that. It's because the staffers and the members don't have the background that they need to write the bills. And so they ask for those to be drafted, and we provide those, and we provide language for the bills. And this is necessary, because without that text and without those drafts, there isn't anybody else to write it. There isn't anybody who knows the system well enough. So if you're there and you have that relationship and you have the opportunity to provide that text, it'll get modified later, especially with the other lobbyists around. But somebody has to write the first draft. And many times that's the lobbyist. The other really interesting thing about this relationship concept is we're always so eager to get results, right? We go up on the hill and we have our sheet, we have our 3, 2, 4 things that we're lobbying for and we're advocating for, and we want to see something happen. We want to see it happen. We want them to go back to Congress and pass a bill the next day. And nothing happens, and nothing happens, and nothing happens. And then 4 years later, there's some huge omnibus bill. And because of a lobbying effort that has been consistent, and because of a relationship that has been consistent over years, a tiny little piece of that huge omnibus is exactly what we asked for 3 or 4 years prior, because we got it in because of those relationships. So you have to maintain this contact, you have to maintain these relationships, and you have to show up every single year, twice a year, 3 times a year, once a month, however often you can go. There's this old adage, if you're not at the table, you're on the menu. Yeah, that's true, but it's not nearly as malicious as you think, right? People aren't necessarily stabbing you and trying to kill you and eat you because you didn't make it to the meeting. They simply forget about you. If you don't show up over and over again and say, yes, we still need NIH funding for arthritis research. Arthritis did not go away. We still need arthritis funding, NIH funding for arthritis research. They take it off the list. They're constantly trying to cut. And if somebody hasn't come to them recently and said, that one's important, they assume it's not important anymore and it goes away. This happens on the regular, that something disappears and drops off of a bill or drops off of a funding line, and everybody raises Cain, and the people who are putting it together say, well, why didn't you come tell us? We did. We didn't tell us recently. So I hope you won't be as afraid of lobbying and I hope it won't give you necessarily the terrible taste in your mouth that I think it gives a lot of us when we think about it. And I hope you think about participating, and there are some wonderful opportunities. I'll put slides up in a second to participate through the ACR if you want to do that. The other thing you can do is write a check. You can write a check to RoomPack if you're feeling guilty or you want to do that kind of thing. But I would much rather, and Howie would kill me. Howie runs, as a rheumatologist in New York, he runs RoomPack. He would kill me for saying this, but I would much prefer you sign up and go to the Hill with us than write a check to RoomPack. We'll do both. That would be best. But to get the engagement, to see what happens behind the scenes, to participate in those activities and those groups, like so many of your peers and so many of the people around, especially at the powerhouse of the University of Nebraska, have been doing for years. It's a lot of fun, and I encourage you to get involved. Okay, the ACR. This is the agenda they gave me to talk about with you guys. Has an office in Washington, D.C. That's relatively new in the history of the ACR. That office has been up and running 5 years now, Dr. Odell. How long? Something like that?
Yeah, probably a little longer than that.
Maybe a little bit
I guess
longer.
it depends on when you call an office,
You're right.
live there.
Right. There's some important committees that engage in our advocacy efforts more than others. We'll talk about those in a minute. I'll briefly put up the priorities. You've heard them all a million times. We can dive into them if you're interested. This group, I think, knows those pretty well. And then the coalitions piece is an extremely effective and important way the ACR gets things done in Washington, D.C., and they're quite good at it. It really lets the ACR and it lets the rheumatology community punch above its weight by forming these coalitions. The state of play in Washington, D.C. is what you already know. It's highly divided. What's coming in the 24 Congress, God only knows. And then there's the Hill Days and RoomPack. Okay. The number to call if you want to get interested in, or if you want to get involved with advocacy through the ACR is Marcus at unmc.edu. He's the most recent, most highly involved. He's your recent court chair, knows all about it, knows the ins and outs. And if you are interested in something like that, I'd reach out to him first. If you want to talk to somebody at the ACR, the guy to look up is Adam Cooper. Lenny is our main lobbyist in Washington, D.C. Amanda is leaving the ACR for a different position. Joseph runs the state programs. And I haven't met Ashley. She's kind of new to the team. This is just a quick list of the committees. If you're interested in advocacy, some committees get deeper into this than others. GAC is at the top of the list. Government Affairs Committee, Fund Committee, dynamic, active, does a lot of stuff, high profile, works closely with Cork, and almost always has these real charismatic leaders, people running around in Washington, D.C. and getting their pictures taken with lawmakers. Cork at the bottom of this list is probably number 2 and has a couple of important subcommittees, one called the Affiliate Society Council and the other one called the Insurance Subcommittee. If you really want to know about the dirt on insurance companies, sign up for a for a tour of duty on the Insurance Subcommittee. The Insurance Subcommittee is the arm of the ACR that fields all the complaints from the people out in the trenches about the insurance company shenanigans and then tries to solve those problems and interacts directly with the insurance companies and with government payers and changes their policies and gets them to say, oops, sorry, we made a mistake, and reverse something for the benefit of our members and our patients. It's incredible. They're the tip of the spear and they're the front line for the interactions between our members and the insurance companies. Room PAC is our PAC. Obviously, it's a separate group and has to be separate for IRS and legal reasons as well. ACR priorities. I'm going to blaze through this pretty quickly, but we can talk about any of the individual ones if you're interested in. We try to couch almost everything we talk about in terms of access to care. It covers a lot of bases for the things that we care about, the policies that we care about. Emphasizing the importance of access to care. It solves a lot of problems for providers, solves a lot of problems for patients. We have a huge workforce shortage. We're much more nuanced in our understanding of our workforce shortage than we used to be. It used to be all about getting more fellowship spots and getting the fellowship spots that existed funded. We're now much better at that than we used to be. And what we've realized is 2 hugely important things. One is we don't just have a workforce problem, we have a maldistribution problem. And you can't solve a maldistribution problem by simply throwing more fellows into the mix. And number 2 is you can't treat peds like adult. The peds workforce problem is very different from the adult workforce problem, and they require different solutions. Medicare reimbursement's a big problem. We spend a lot of time advocating to make sure that Medicare doesn't cut rheumatologists. Had a big win for this in the last couple of years ago, where cognitive care took a bigger piece of the pie, Medicare reimbursement pie, away from proceduralists, surgeons. Turns out they didn't like that, and they reversed it at the local level on most of the organizations around the country. But that we live on to fight another day. We talk about drug pricing all the time, especially in our campaign against PBMs. This is getting some traction. Finally, the FTC starting to pay attention to it. The problem is the FTC is busy with Google and Facebook, but we hear they're number 3 on their list. The PBMs are number 3 on their list. So maybe we'll get some more attention with PBMs soon. And then we're constantly trying to keep the flow of research money not just out of the NIH, but also with some success recently out of the Department of Defense and even the CDC into the rheumatology research community. This is accomplishments in 2023. They're busy. This busy group. There's a lot of contact with lawmakers and regulators in Washington, D.C. Coalitions. This is the thing I talked about. This is just a list of some of the coalitions that the ACR has either founded, some very, very successfully, or participates in on a regular basis, and again, allows us to punch above our weight. Speaking of coalitions, one of the most important voices in Washington, D.C., and kind of a coalition, is the AMA. So the AMA allows us to get attention with issues in Washington, D.C. that we can't as rheumatologists alone. And so our engagement and our involvement with the AMA is very important. That depends on the number of rheumatologists who are also members of the AMA. So when you pay for a membership of the AMA, you're actually helping the ACR advocate through that channel, which is one of the most important channels. This is Washington, D.C., our Congress. You all know this as well as anybody. Highly divided, not changing, and we're in an election year. So I think everybody knows what happens. This is like trying to predict Super Bowls. What to expect in Washington in 2024. I'm surprised they gave me this slide, actually, because I don't think anything's predictable in Washington, D.C. in 2024. And these are people on the move. And I wanted to show this slide, especially because there's some Nebraska showing up in Washington, D.C. and representing. And this department is not just a powerhouse in clinical care, not just a powerhouse in research, but is a powerhouse in advocacy and presence at the ACR as well. And we're deeply appreciative. Okay. If you just want to send in money, send money to RoomPack. I'll tell you a little bit more about RoomPack in a minute, but I would vastly prefer you sign up for one of these two. We go to the Hill twice a year. The first one is in May. It's called the Advocacy Leadership Conference. And where is the other half of that slide? Okay, there's another half of the slides that's not coming up, sorry. We also go in September. There's slightly different meetings, slightly different. We used to say storm the Capitol. We try not to say that anymore. Slightly different approaches. One, we take patients. The other one is really just leadership from the ACR. But the cool part is at the beginning, GAC puts on this wonderful educational program and not only teaches you about all of the items that we're going to take with us and the things we're going to advocate about, but teaches you how to be a lobbyist. It's fascinating. It's very, very interesting. It's intimidating and easy. It's the kind of thing where you're afraid to do it before you go, and then after you wonder what you were so afraid of. It's a lot of fun. So I encourage you to go to one or both. They're both a great time. If you're a fellow, you have, in addition, another opportunity, something called Advocacy 101. This is specifically designed to train up and engage fellows into the advocacy space. This program was invented by Blair Solo, who is recently completed. No, is still currently has one more year left as the chair of GAC. Sorry. Oh, yeah, that's right. She's on there. She's finished. She recently completed a tour of duty as the chair of GAC. But before she was chair of GAC, she invented this Advocacy 101 program. And the whole concept, the other person I want to highlight real quick is Will Harvey, because this whole concept of taking volunteers to the Hill, taking rheumatologists to the Hill, and doing it successfully came about because of Will Harvey's efforts, who was the chair of GAC a couple rounds ago. And previously we used to pay a lobbying firm to do it, and we've moved away from the lobbying firm. We still use them for some special activities, but we now have these organized events where we take patients and where we take providers to the Hill instead, and it's highly successful. Okay, RoomPack. One quick thing to say about RoomPack, nonpartisan. What's that mean? Most people, when they think nonpartisan, they think that means, oh, you give money to Republicans and you give money to Democrats. Well, that's true, but that's not really what we mean when we say nonpartisan. Nonpartisan is your reputation. Nonpartisan means that when you talk to a member or you talk to a staffer, they don't think of you automatically as either being Republican or Democrat. And we strive very hard to maintain that neutrality and to be nonpartisan in those interactions because of the importance of those long-term relationships. Because if you're seen as Republican or if you're seen as Democrat, you don't get asked questions about specific bills because you're not going to have the right information. You're going to have partisan information. And so in order to maintain those relationships, one of the most important things RoomPact does is maintain this nonpartisan stance. Yes, it also means we get money both sides of the aisle, but far more important than that is how we are perceived in those long-term relationships with the members and the staffers. You guys heard about workforce from Dan, so I'm going to skip that and just bring everybody up to speed on RISE. You guys are engaged with RISE, you led the way, you know all about RISE. But RISE continues to grow. We're up to 34 million patient visits. That's a lot of data. 95 practices, 502 providers. We estimate this is 40-ish% of the active workforce in the United States. And drastically important for all the practices that engage with Medicare through the MIPS program. Practices have tried to sever their relationship with RISE and go it alone in their organizations and submit to MIPS, and have given up and come back to RISE because it's too onerous. It's an incredibly important service that the ACR provides through RISE to that portion of our membership. And we're going to have to think long and hard about how to maintain that and especially evolve it as CMS tries to make MIPS go away and move into other quality payment programs. Last thing, some thanks from the Rheumatology Research Foundation. Thank you for your engagement. They love Nebraska because you guys submit great applications, and Ted goes back and runs one of their biggest committees. It's called a council, but it's a committee. Before him, as you're all well aware, Dr. Odell was president of the foundation. Lots of engagement and lots of contact between your two organizations. Over the years, $1.9 million has come out of the foundation and gone to the University of Nebraska. Congratulations, well done. They remain in thin, rare air, I guess is how you say it, rare air in terms of charities. They're highly efficient. It's less than 1% of charities maintain a 4-star rating for 15 years in a row. It's an incredible badge of honor for that group. And a lot of it has to do with their efficiency. The transparency is pretty easy. The efficiency is difficult. When you give money to the foundation, it goes to the cause. It doesn't go to buying paper for the printer and administrators who shouldn't have their jobs and things like that. So if you are interested in being a philanthropist, I encourage you to think about the foundation. Many people are interested in philanthropy. And if you're thinking about philanthropy, if that's something that's interesting to you, I encourage you to think about efficiency. And I encourage you to think about the target. Who is getting the money? And the foundation does both of those things exceptionally well. They have an incredible track record for picking out the best and brightest and funding their research, and they're incredibly efficient, largely because of their relationship with the ACR and their sharing of resources with the ACR. So it's a wonderful place to be a philanthropist, or to start to be a philanthropist if you want to dip your toe into that pool. That's it. Thank you very much for your time. Safe driving.
Let's see here.
Do you guys in Zoom have any questions before we close it out?
No.
Dr. Odell.
No anecdotes. But when I was in my ACR days, RF days and stuff, some of the most enjoyable times we were actually visiting the Hill and learning about everything going on there. I love to be in DC anyways. It's so inspiring. But to some of the points you were making, so I visited the Hill several times a year for probably 2 decades. And it is really all about relationships. Some of the most important relationships I had were there because of my children, because all the staff were my children's age, and 2 of them were best friends with my kids. And those relationships paid off in many ways. For bills we were talking about, but also personal stuff that we were doing correctly. So relationships and understanding how young those people really are and how receptive they are to information. And, you know, when you're on the hill, most important is to start thinking everything about it.
They are acutely aware of their lack of experience, these young staffers. They're afraid of it, right? They know full well that it's a huge liability to never have worked outside of development or never have had a full-time job outside of development. And they're eager for information, they're eager for your advice, they're eager for your perspective. They know it's how the system works and they rely on us to provide them with that information. So it's not all bad. They're, as Dr. Odell is saying, they're highly receptive. They're like sponges. You just gotta go talk to them.
Yeah.
McCune, did you have a question?
Thank you.
No? Okay.
No, thank you.
All right. All right. Well, before we go, I'm going to go over some slides real quickly of our business meeting. Let's give a round of applause for Dr. White.